The patient should be prepared by establishing intravenous access and full monitoring. If a lignocaine nebulizer is used, it should be timed to finish just as topicalisation begins. Unless contraindicated, an antisialagogue will enhance topicalisation by providing dry mucosa in addition to improving the endoscopic view. We use glycopyrrolate 4 micrograms per kilogram, given at least 30 minutes beforehand. Oxygen may be administered via a nasal speculum held in the patient's mouth. Using a dosing calculator, all lignocaine doses should have been drawn up in advance using separate labelled syringes. Doses given in this video are for a 70 kilogram patient. Inspect both nostrils and the floor of the nose with the nase endoscope to assess patency. With experience, this will make prediction of nasal passage of the endotracheal tube more accurate. The inset picture demonstrates the nasal anatomy. For the left nostril, the septum is seen on the left, the floor of the nose at the bottom, and the inferior turbinate in the top right corner. The preferred route for passage of the fibroscope through the nose is between the inferior turbinate and the floor of the nose. When comparing the two sides, it can be clearly seen that the subject's right nostril has a wider passage through this area than the left nasal route. Six metered dose sprays of a combined local anaesthetic and vasoconstrictor, such as cofenalcaine fort, should be used in the best nostril whilst asking the patient to sniff deeply. The next step is administration of 4% lignocaine to the nose using a mucosal atomizer device attached to a syringe. When passing the endotracheal tube, a significant source of discomfort is at the nasal opening, so start spraying here. Ask the patient to sniff on spraying and use 0.5 milliliter aliquots whilst advancing the atomizer into the nose. Aim to use all the volume and finish at the back of the nasal cavity. Swap the nasal prongs to the nose before oral topicalisation of the back of the throat. Again, using an atomizer, spray both tonsillar pillars and then the posterior pharyngeal wall. And finally, direct the atomizer downwards to spray towards the cords. Return the oxygen prongs to the mouth. Insert the nase endoscope into the favoured nostril and advance along the nasal floor. Note that the endotracheal tube should be loaded on the fibroscope at this point. It was omitted in this demonstration video as the subject was only topicalised and not intubated. Once through the nose, direct the fibroscope tip inferiorly. Advance past the tongue base until the epiglottis is visualised. Centralise the epiglottis in the field of view and spray 2 millilitres of 4% lignocaine directly down the endoscope suction channel. Note that this is drawn up in a 5 millilitre syringe, also containing 3 millilitres of air, which is injected to follow the lignocaine to push it through the channel dead space and provide a wider spray for better coverage. Advance the scope over the epiglottis to visualise the vocal cords. Centralise the left cord and spray with a further 2 millilitres of 4% lignocaine, and then repeat on the right cord. The main image demonstrates the use of an air chaser. To avoid contact between the scope and cords on coughing, avoid getting too close. As a guide, the cords should not fill the field of view. The airway is now topicalised. The scope can be advanced through the cords before railroading the endotracheal tube over it. With the oral topicalisation regime, the emphasis is on obtunding the gag reflex more so than with the nasal route. The oral nebulizer is set up to avoid wastage of lignocaine. Here we use a mouthpiece and ask the patient to only breathe through the mouth. Again, using an atomizer, spray both tonsillar pillars and then the posterior pharyngeal wall. And finally, direct the atomizer downwards to spray towards the cords. For oral awake fibre optic intubation, a bite guard is essential, both to act as a conduit for the scope and for its protection. If using a Berman airway, start with the middle size and ask the patient to insert the airway themselves. If they don't tolerate the airway, ask where it is uncomfortable. If at the base of their tongue, use a larger Berman. If at the posterior pharyngeal wall, use a smaller size. For the epiglottis and vocal cords, the technique is the same as for the nasal route. Note that the video is in real time. 4% lignocaine works rapidly, so no pauses are required. We have found that the use of an epidural catheter is not required to facilitate dispersal of spray if an air chaser is used to achieve a good jet. It is important to aim the scope at the cords and epiglottis to ensure good bounce and coverage. For smaller patients, the maximum allowable dose of lignocaine may limit topicalisation. The nebulizer should be the first component of topicalisation to omit. We have found it to be the least valuable in volunteer training courses with colleagues. If the airway is still not tolerated, use a small, round bite guard instead. Some form of bite guard is essential, as the need to bite down if gagging is very strong and easily damages the endoscope. With the oral route, it can often be difficult to maintain a midline scope position, hence the benefit of an oral conduit. It is essential to supply oxygen at all times to patients wherever possible. We do not recommend insufflating oxygen down the suction channel of the scope. There are case reports of this leading to gastric injury.